starting in with
30. Okay. It usually says that we are now recording or something, doesn't it, though?
again.
Wait, but it has that thing.
Yeah, so it's fine.
Okay. Okay. All right, now let's go. So this is a female 3-year-old hedgehog. We have progressive third eyelid swelling and exophthalmia with dorsolateral strabismus over the last 2 months. So the gross view really, I think, exemplifies what was going on pretty well. We have the adorable tiny little hedgehog globe right here, adorable tiny little hedgehog lens, and this large sort of tan white mass in the orbital tissue. The optic nerve is kind of buried in there. You can maybe make it out as sort of roughly here. And that's what we've got. So let's go straight to the histo. Nope. Okay. There we go. All right. There we go. I go boop, and that's perfect. So here is our adorable little globe. And the globe itself is just fine. Well formed, nothing going on. We have a nice little optic nerve head and optic nerve. And then over here in the orbital tissue is where we have something of interest. So we have this large neoplasm. It's highly cellular. You can kind of see from the magnification already that it's got sort of anastomosing cords and tubules of cells. Look closer to kind of prove that. It has some degree of palisading around blood vessels. We've got that going on. Some lobules. Okay. Let's see if I can find, I think at the edges, maybe a little bit more. We have some tubular looking structures.
Better use the green arrow because the other one is too small for it.
The other one is too small. Use the green arrow. All right. All right. Some maybe more tubular structures there and there. And there. And otherwise sort of lobules, anastomosing cords, and tubules. So long story short, this is a carcinoma. It's an orbital carcinoma. So there are probably 2 more likely sources that this could have arisen from. We've got lacrimal gland and we've got Harderian gland. Probably the 2 most likely sources. We do have some non-neoplastic glandular tissue next to the tumor, here and here on both sides of the globe. There's a little bit of fat in it. And you can make that out here, a normal non-neoplastic glandular tissue. And then, interestingly, next to the neoplasm over here, sort of right next to the neoplasm, we have these sheaths of fat with some tubules of epithelium, maybe ducts sort of here and there among the fat immediately adjacent to the neoplasm. So it's unclear exactly why this part of the gland seems to have been taken over by fats. We hypothesize that it could be associated with atrophy of the gland. It could be just physiologic for this particular animal if they're keeping some extra fat in their orbit. But that's kind of another interesting feature next to this tumor that we saw. But long story short, an orbital carcinoma, probably of either the lacrimal or Harderian gland in a hedgehog. This has been published a few times in hedgehogs, sometimes as actinic carcinoma, or you could just refer to it as an adenocarcinoma, probably just fine. And that's about it. So let's go back to the PowerPoint, which can become full screen.
The margins compromised.
They were. So these are at least our margins or edges of the neoplasm, and they were incomplete or dirty. Good question. Let's see. All right, there we go. There you go. Oh, also potentially salivary origin. I didn't include that, but there are some salivary glands that are a little bit closer to the orbit, like a zygomatic in a dog, for example. All right, that's that hedgehog. If there aren't any questions, we'll go to the next case, which is one of my favorites. Okay, So this is a horse. It's the paperwork. So this is a neonatal foal, basically just born, at 8:30 a.m. with dystocia. This was the result of a natural mating between a quarter horse mare, 8 years old, and a quarter horse stallion. So that's what we've got. So I don't know if this foal was born already dead or if they euthanized immediately after. I believe it is the latter. But the condition in this baby was, basically not going to be compatible with a high quality life. This foal also had some abnormalities of the maxillae and skull, but we're focusing on the eye because we're a bunch of eye nerds. So, presumably also brain, but we'll get to that. So here's the eye with none of the lids trimmed, so you can see the eyelid abnormalities as well in this animal. So there was a single orbit in this foal. There was a single foramen for the optic nerve to come out. We can see on the hemisected view here that there was a single optic nerve coming out the back. And there was basically a single globe occupying that single orbit. So that was very interesting. We do have more images of this, but not in this PowerPoint at present. So we have the sort of a ventral canthus here, if you will, and we have maybe a slight dorsal canthus or so up here. But yeah, basically some kind of eyelid abnormalities as well. There's post-fixation artifact in the cornea, so it's a little cloudy, but you can still probably make out that the pupillary shape here is abnormal. It kind of has a little jagged edge ventrally here, maybe a little bit more well-formed dorsally, and we'll take a closer look at that on the histology. And then on the hemisected view, so we've got cornea here. This globe was sectioned in a horizontal plane, so kind of right like this. The lens, there was a single lens in the middle, but it was sort of this teardrop shape with a sort of cone-shaped posterior lens. And that sat in this sort of septum of sorts, sort of an incomplete septum, coming from the optic nerve-like projection in the back. And we'll take a closer look at this septum too. There was actually a very thin, almost tissue paper-like tissue coming around the lens here and here, which you can't really make out, but we'll look at on the histology closer. And maybe you may have to kind of squint or sort of imagine, but there's actually 2 optic nerve heads, one on either side of this sort of incomplete septum down the middle. So some interesting features of this globe grossly. Let's take a look at histology. Okay. See if the subgross works okay for us. So your cornea is to your left. You have the iris and ciliary body. And already in the anterior segment, you can see a little bit of abnormality. So while at this level, the trabecular meshwork is fairly well formed, we'll look at it closer on a better view because the subgross can often be a little blurry, as you can see. But from back here, you can see that the ciliary body plica basically appear to come out of the posterior iris. So there's some degree of malformation of the anterior segment already in this section. And this is sampling the area of the pupil that it was a little bit better formed, sort of the dorsal pupil, pupillary margin. We'll look at the ventral in a moment. Coming around to the back, which is more exciting, we have this sort of partial septum coming right down the middle. There's this giant piece of cartilage just hanging out there right in the middle, which is kind of cool. And then there's all this sort of jumbled eosinophilic tissue, which we'll look at closer here. We've got retina coming out on this side, we've got retina coming out on that side, and we've got these little tiny optic nerve heads, one on each side. Very cute. Here also off to the side is that cute little lens. I'll probably show the lens section on a more superficial section than this one, but we'll come back to the lens. All right. Have I flipped it? I have flipped it completely around. Now the cornea is on our right. So just get oriented. Here's the cornea. Here's a closer view again of that well-formed trabecular meshwork. You got well-formed pectinate ligaments and the meshwork here, but that slight anterior segment abnormality here, a little bit closer and in better focus. But the back is the more exciting bit. So here we have that big piece of cartilage down the middle again. And it's actually better on the superficial section for these two little mini optic nerve heads on either side, but there's one, there's an even better two. And actually the retina coming out on the side that's sort of away from that incomplete septum is pretty okay. It's actually well organized. We've got the layers that we expect. We've got a good number of ganglion cells in there. So it's doing reasonably okay. I postulated that probably there's some degree of detachment or non-attachment in this case, but it's hard to be sure. But apart from that, the retina is okay on that side. But then towards the incomplete septum, which is really cool, we kind of have retinal-like elements sort of blending into this tissue in the middle, forming rosettes, sort of jumbled and disorganized. So we have retinal dysplasia closer to the middle, where we've kind of got this fusion. Apart from that, there are these sort of primitive neural-like elements here, just sort of all jumbled up together, and a large number of these pinkish globules, oftentimes with nuclei in them, sometimes without. And you may be somewhat reminded of lens tissue with this. So keep that in mind if you are, because we'll take another look at one of the other sections to show you off some more. We actually have the lens capsule coming in right here. So this is exactly where that sort of point of the pointed posterior lens sat, sort of right nestled into this abnormal tissue down the middle. So that's all I wanted to show you on this section. I'm going to go back to the superficial section, which has less of a nice anterior segment, but some other cool things to look at. So same eye, more superficial section, and this shows off a little bit more of those globules that we were seeing earlier. And in fact, there's almost in this level just like a complete but tiny and very degenerate looking little lens sitting right back here. So a lot of these globules are basically lenticular metaplasia or just lens globules, lens protein kind of in the mix with this sort of incomplete septum here. And some interesting stuff there. This level also shows off that how a lot of this jumbled tissue is basically neuroepithelium. There's even some of the pigmented epithelium here. So this basically looks like it could have been like ciliary body, but jumbled and disorganized. So that's pretty cool too. And just a better view of the two optic nerve heads, one on each side. Here is one. There's two. So really cool case, not one that you see every day. Before I close out though, let's show you the ventral pupillary margin, which had that sort of unusual shape to it. I think I prefer the 1000. Take a look. So this is just a sort of orthogonal section through that ventral pupil. So we've got the cornea here progressing towards the edge. And the anterior segment here is pretty malformed. We have this kind of thin and I guess basically dysplastic iris, which doesn't have a lot of the normal stromal elements. The epithelium is kind of jumbled here. As it comes back, it doesn't really form like an obvious ciliary body with pars plicata or anything like that. And then it just sort of ends in some of this sort of primitive kind of dysplastic tissue with a little bit of that lenticular metaplasia coming back into view again as we got closer to that incomplete septum in the back. So yeah, just some degree of malformation here as well. So a really cool case. And if you haven't already guessed the main diagnosis in this case, we'll pull it up here. Cyclopia. So there are two terms that kind of describe a spectrum of presentations along the lines of this type of mutation. There's synophthalmia, which is probably more appropriate when you have sort of roughly two fields, like two eyes basically that are like partially fused into one orbit. We chose Cyclopia in this case because it's basically one eye, even though there are elements of two sort of incompletely separated or fused together. Oh, shoot. I didn't show you the lens, but there are, okay, we'll go back. That's true. Why not go back?
Right.
All right. I wanted to show you this section of the lens because I thought it was better and prettier, but I forgot. But now I remembered, so it's all over it. Here it is. So this is our sort of teardrop shaped lens. We've got the wide end over here, and we've got the pointy end over here. And as you kind of walk along what should have been the anterior level of that lens, you kind of get multiple bows coming into view. So let's actually walk along this side, I think. Maybe a bit of a bow right there as the nuclei sort of distribute towards the center. Higher magnification. All right. There we go. Bit of a bow right there. Right there. There's lens epithelium coming into view. The lens capsule is artifactually separated. Definitely a bow right there. That one's a nice one. A little bit of cataractus degeneration, maybe. So yeah, basically this lens kind of had a couple of abnormal areas along its edges, multiple bows, which suggests it's sort of two lenses fused together. There was a sort of subtle, which didn't show up well on the photograph, so I didn't put the photograph up, but there's a subtle sort of divot down the middle of this structure as well. Almost like it was kind of two lenses fused together. So, okay, now the lens has been shown. And there we go. So, Cyclopia. There are probably two possible causes in this case, either just genetic mutation that was sort of out of the blue, or we could have had plant toxicity. For whatever reason, Gelat, specifically like a different species of veratrum than we often think of, rather than Veratrum californicum, it's like air something. It's in Gelat, basically a different species, but basically in the false hellebore type of a group. And so if you eat that plant, or if the horse, or probably more typically sheep, eats that plant at a certain stage of gestation, it can produce these abnormalities. This foal almost certainly also had prosencephaly, so the hemispheres of the brain don't separate well in this condition either. And that's part of what leads to the eye not being completely separated out either, and a single eye in the middle. That is this case.
One thing that's interesting about the Veratrum californicum toxicity is the fact that exposure to the plant or the toxic elements should happen at a very specific gestational date for this to happen, right? Where the optic cup is forming. Otherwise, this will not happen. There's a lot of relatively old research done with that, where they will, intoxicate ewes that were pregnant, and it's very different gestational days. And if it doesn't happen at that window of time, nothing happens. If it happens prior or after, they don't develop Cyclopia or squamous. It's kind of cool.
Mm-hmm. Yeah, less common in horses too. So
right,
a very unique case.
And we aren't sure, right? There's no history of presence of the plant and the property or anything like that we know of.
Yeah, not that we've been told about. No.
Okay. Okay.
All right. All right. So next up, we have a 2.8-year-old male Labradoodle dog. that presented with a history of ocular hypertension, uveitis, and retinal separation in the left eye. The IOP, I think that says 31. It's either 31 or 51. Not good either way. That's true. For again, either 3 or 5 months. The other eye was normal in this dog. So grossly, we said the globe was boophthalmic with 2 exclamation points. So quite boophthalmic. Oh, there's my arrow. So the cornea was kind of cloudy here. We noted that the lens looked kind of a little flattened in like the anterior posterior plane, which will come into play maybe a little bit later. The vitreous was liquid. The retina here is detached, and it's no longer, it's also torn. This is what I'm trying to say. It's detached and torn, and probably the optic nerve head. It's probably cupped in there, but we'll take a look at it histologically. So here's our subgross of our globe. Not a whole lot to really take into account. It is quite a big globe. We did have to do a Swiss roll where we had to cut the globe kind of on the posterior end and kind of curl it around itself to make it fit into the cassette. And again, you can kind of see the flattening of the lens, which can be sectioning artifact, but since we saw it grossly, more likely to be real. All right. So, there you go. Our corneal epithelium was a little bit hyperplastic, a little bit keratinized. Probably not surprising given how large the globe was.
Focus up there. There you go. Put it off.
Just double check here. All right. And as we move around, we notice that the base of the iris leaflet here comes down and around, crosses the anterior or the iridociliary angle. And it attaches right to the end of Descemet's membrane that tapers. So we have no presence of a cleft. We have no presence of trabecular meshwork. We've got some posterior displacement of the aqueous outflow and the sclerovenous plexus. We'd like to double check the other side. Got the same sort of finding here. Again, base of the iris coming around, crossing the angle, attaching right to the tapered end of Descemet's membrane, and the sort of posterior displacement of the other angle segments there. The lens did have some posterior migration of the lens epithelium and some little bit of cataract exchange in the posterior here. And our retina is detached. And we come up here, we can see where we've got a nice sort of rounded edge of our retina here. So more indicative that this is a true tear and not an artifact of sectioning or processing. So we have that here. There is a little bit of mineralization or in this little puckering here. Yeah. There is a little bit of mineralization here, sort of like the RPE cells, which we just, I believe we see sometimes.
Mm-hmm. Yeah, sub-RP concretion sometimes happens with chronic retinal detachment. We just don't know what they are. They're cute.
They're cute, cute and adorable. But we do have our loss of ganglion cells and atrophy of the rest of the segments of the retina. The optic nerve head is cupped, and we've got some gliosis in the optic nerve. And those were the main features. Ooh. Oh, that's 100. That's why. Ah. Not 2x. All right. So, yep, in this young dog with all of these features together, we have anterior segment dysgenesis. The cataract likely congenital. And I think we've seen that sort of oddly shaped lens where it's sort of flattened on the anterior posterior plane as well. In these cases, again, retinal detachment, tear, and atrophy, and then just our chronic congenital and juvenile glaucoma in this case. Usually these cases are unilateral. But we still recommend gonioscopy for the remaining eye just to double check to see if there's anything else structurally wrong with the other eye. And see if there's
Yeah, that's a
anything going
question
on
that
there.
comes up very often from our clients in terms of in these younger dogs, do we expect that the other eye is gonna go the same way? And as far as we know, we've been looking into it. We started a couple of research projects, but as far as we know, the second eye going bad with anterior segment dysgenesis is not as predictable as when we make the diagnosis of corneal dysgenesis. So it's possible, but not as common. At the same time, we have had cases where there is bilateral, right off the bat, bilateral glaucoma with these younger dogs, and there were cases where we received the first eye and there is gonioscopy of the other eye that already shows some alteration. So it depends on the clinical presentation. If there are signs of malformation of the anterior segment of the second eye or already signs of glaucoma, then it could be bilateral.
All right. No, this is the left eye from a 9-year-old Labradoodle male neutered dog with a history of being seen at the DVM back in August of 2017 for episcleritis and lipid keratopathy of the left eye. They prescribed some tacrolimus and prednisolone acetate, and there we saw minimal to no change at the recheck exam a month later. Then the dog was not seen again until it presented in June of this year. And they noted that the dog had a recent onset of discomfort and increased redness in the left eye. Had a chronic history of cloudiness and inflammation, and showed significant blepharospasm and focalized when palpated around the eye. So quite painful. They said the globe was moderately blue ophthalmic and there was severe scleral injection and corneal vascularization. They could not perform an intraocular exam. The right eye was comfortable and visual and seemed unaffected by what was going on here. They had an IOP of 43 in this eye. Again, ophthalmic and non-visual, so they elected enucleation. And this was the clinical photo that they sent to us. It's quite dramatic. All the scleral, or all the blood vessels and cloudiness, and can't really see kind of what you're looking at here. Yes, so we didn't have a gross cross-section of this particular case, but we pulled one from this entity from a different case, just to give you an idea of what it might have looked like on the hemisection. So you'd probably see thickening and kind of distortion here in this scleral and episcleral tissues. In our case, it would have extended all the way around. Let's see, some thickening and opaqueness to the cornea. In our case, the vitreous was liquid brown, and unlike in this picture, the retina was detached and torn as well. And their optic nerve looked quite brown, grossly for our dog. So I will show you what this looks like histologically. Once I have the slide, there we go. All right. So here our subgross. So here's our cornea. You can already tell it looks a little bit more blue than it should. There's lots of hemorrhage in the chambers here. I guess you probably can't tell too much, but that blue coloring does kind of go around on the sclera as well. And then our detached retina and really serious cupping of the optic nerve head in this case. Again, given that it was ophthalmic, it was probably a little hard to fit into the cassette. So let's go look at our changes here. So again, lots of hemorrhage and some interesting blue dots that we'll get back to. But here's a look at our port cornea. The corneal stroma is just infiltrated by numerous neutrophils, lymphocytes, plasma cells, blood vessels. There's some fibroplasia here. They did describe a lipid keratopathy, which all these sort of acicular clefts down here in the mid stroma goes along with that. There's some hyperplasia of the corneal epithelium. So some good corneal disease going on here. So we come up here, the posterior side of the cornea, there's a thick retrocorneal fibrovascular membrane. There's hemorrhage coming in, splitting kind of this deep corneal stroma here. And as we look at this very hemorrhagic iris leaflet up here, get it more into view here.
Can you show Destiny's membrane just so that people realize how? Oh, I'm sorry.
There is this thick membrane on top of the iris with Descemet's membrane that has been pulled away from the cornea stroma. And the blue dot over here was to show you a break in Descemet's membrane. So it looks like this eye had some trauma on top of it. We've got a red fibrovascular membrane on the posterior aspect of this iris. And it also comes along the anterior lens capsule. So we have pupillary fibrovascular membrane and all the hemorrhage along with it. Going back here. And then we can follow this inflammation and severely infiltrates the sclera. I'm going to follow around to my handy blue dot, number 2. And because I think these were the best areas that we had. So we had a lot of lymphocytes, plasma cells, macrophages in here, and kind of multifocally in with the inflammation, we have our collagen of the sclera. And a lot of times the inflammation seemed to be centered around these sort of degenerate and devitalized areas of collagen. Almost as if the inflammation is attacking the sclerocollagen. So that was, I just showed for that. So again, lots of hemorrhage. We'll keep going back. The inflammation keeps going in the muscle. It's a little less intense towards the back of the eye. And okay, there we go. Here's our marked cupping of our optic nerve. The retina is detached. There's a bunch of acute hemorrhage associated with it. Again, come back out here. It is torn because we've got a nice little rounded margin here on that area. And then we don't have much optic nerve in that cleanest section, but we had the additional one. And the reason that it looked brown grossly is because there was abundant hemorrhage in the optic nerve as well. It seems mostly acute. There were some areas where there were some hemosiderin-laden macrophages, so indicative of some chronic hemorrhage. So some extreme trauma to an already hurting eye, probably. Yes, I think that was hit all the main features there for that. And so for this entity, we had a severe diffuse lymphoplasmacytic and granulomatous scleritis, panuveitis. Like I said, it went into the muscles, so myositis, and then there was sclerocollagen degeneration, which is consistent with necrotizing and granulomatous scleritis. And again, that severe inflammation in the cornea, the keratitis and the vascularization, lipid keratopathy, and all those lovely corneal changes that go along with probably exposure from all the ophthalmos that was going on. This necrotizing granulomatous episcleritis, scleritis, thank you. Episcleritis is a different thing.
The only reason I said that is because people already confuse this with NGE, which is nodular granulomatous episcleritis. And the reason we put necrotizing / granulomatous is to make people understand that we're talking about this one versus NGE. The nomenclature is all over the place in this.
Yeah. Too many similar letters. So the necrotizing granulomatous scleritis likely represents a immune-mediated inflammatory reaction, kind of an unknown etiology, but does seem to be kind of centered on the collagen, and causes those devitalization areas in there. So it is reported to be a bilateral disease that's really aggressive and requires like lifelong immunosuppressive therapy, especially if the other eye develops disease. And I guess, but here in Coplow, we kind of have few cases of bilateral disease. So kind of just keep that in mind as a grain of salt kind of thing. And then again, for this case, blunt force trauma on top of all of that, with all the hemorrhage and separation of Descemet's membrane and breaks and stuff, and the glaucoma secondary to like membrane formation and all the synechia that were present in the eye. So
yeah, that cornea portion of it is interesting because it's not necessarily described in the classic presentation of this disease, but we have seen cases like that where it appears that the inflammation extends also into the corneal stromal collagen. And the corneal stroma is obviously basically or anatomically different than the sclerocollagen, so the changes tend to present with a more significant component of a lipid keratopathy too. So it's hard to tell, if it's the lipid keratopathy is a thing on its own or it's just a secondary phenomenon. or response to the infiltrative inflammatory process into the corneal stroma. And sometimes the inflammation centers and it's mainly targeting the scleral collagen, but it can sort of spill over into the either adjacent uvea or episclera and orbital tissue in a lesser degree. But in terms of, for pathologists out there, in terms of the diagnosis, the main feature is identifying that the sclera is the main target of the inflammation and the presence of that granulomatous lesion with in areas surrounding that devitalized collagen. All right. See things up here. Okay. Here's our next case. 142. This is a 10-year-old female spayed Cocker Spaniel. It has, we got the right eye with diagnosis of KCS and pigmentary keratitis and a corneal mass that the clinicians want to rule out a granulation tissue or neoplasia or something inflammatory or infectious. So the dog is blind, there's a stromal ulcer, and they are talking about that mass. Let's see what else. And that's about it. So this is what we received. We got two images. One, it's a frontal image of the globe where you can see extensive pigmentation of the cornea. It's roughened, sort of lackluster pigmented cornea, and there's this well-delineated white mass, lobulated, some areas of discoloration. There's a center area that could be an ulcer, but it's relatively easy to identify on this image that this area differs from the rest of the cornea. On cross-section, that mass or the lesions are mainly at the cornea. Here's the inner aspect of the cornea. Here's the acantous membrane. There's edema. You can see this gelatinous appearance of the corneal stroma, and that's where that mass was located. You can see the white tissue extending into the stroma, pushing it outwards. And also how interesting it is, we often talk about how you don't really need a lot of melanin to make something look very, very dark and very, for something to look very pigmented clinically. And you can see here that mainly the pigmentation is on the very surface of this cornea. And if you look at it from the frontal view, it's basically, black, brown, right? Another very cool feature is the presence of massive asteroid hyalosis in the vitreous, all those thick dots. It's a non-specific degenerative changes that we see in the vitreous in older dogs. Probably not necessarily associated with the corneal disease in this case. So let's move on to the slide. Here it is. Here's subgross. As you could see on the gross image, very quiet, relatively quiet globe overall. Most of the changes, most of the business is here in the cornea. Here's the limbus. Right? You can see some identifiable deep corneal stroma and that infiltrative lesion more towards the surface. The rest looks pretty normal. So let's jump right in. Around iridocorneal angle. This is an additional section that we got from the iridocorneal angle with a little bit of that mass. Let's ignore that for now. Optic nerve. Coming around, and here is our cornea with our lesion. Some of this central portion is not sampled. This is a little bit of an artifact. But, so let's start with the periphery. And then we'll focus on the main lesion here. So the epithelium is keratinized, hyperplastic. You can see how undulating the basal layer is, and pigmented. Again, you know, the same point that I was making earlier, how much more impressive the pigmentation is grossly than histologically. There are melanocytes in between the keratinocytes here, and you can see them everywhere. There's free melanin in the superficial corneal stroma. So as you know, pigmentary incontinence and inside some macrophages. There's also on top of it, fibroplasia of the corneal stroma with vascularization and the presence of lymphocytes, plasma cells, and some foamy macrophages everywhere. Right, but the main thing is, if you keep following the corneal epithelium, it's not normal by any stretch of the imagination from at this point, but suddenly the epithelium goes from hyperplastic to a little more atrophied, and all of a sudden you can almost put the arrow where the neoplasia begins. So from this point on, the epithelium goes from atrophy to neoplastic, right? And now you have epithelial cells that are diving deep into the corneal stroma. You can see them marching down and dissecting between the corneal stroma lamellae. These cells are forming cords, nests that are floating or, you know, infiltrating the stroma. Let's try the other side of this lesion and do the same thing. So the surface here is quite ulcerated and necrotic. There's this serocellular crust formation there. More of the neoplastic population of cells. Let me go on lower magnification and we'll do the same thing. This is a very useful trick. So this is a squamous cell carcinoma. No reason to keep beating around the bush. But one of the things that we find very often on those surface squamous cell carcinomas is this very abrupt transition from relatively, well, I was just going to say relatively normal after saying it's not normal. So I would say non-neoplastic epithelium to a neoplastic epithelium. So this is folded on itself right there, but it's right there, right? You can see where the basal layer disappears and the cells jump towards the dark side and become neoplastic, right? So right there we got some lobular structures forming indistinct cords. There's a fibrous reaction around it. So a desmoplastic reaction, lots of mitotic figures everywhere. So in terms of diagnosis, this is not that challenging. This is a squamous cell carcinoma. Location-wise, it is a corneal squamous cell carcinoma. The reason we're able to say that in this case is because it's completely localized to the corneal epithelium. You see normal corneal epithelium in both ends, and the conjunctival epithelium is not affected, at least at this section right there. Very often we have surface, ocular surface squamous cell carcinomas where the mass expands both the conjunctival and the corneal epithelium, and it becomes hard to tell the tissue of origin. It doesn't really matter, but it's nice to be able to say that this is a corneal squamous cell carcinoma, right? Margins are clean, and as it's often the case with dogs, there is a background of corneal disease. We know we've seen the lymphocytes, the plasma cells, the vascularization, and the pigmentation. So it goes with their history of a pigmentary keratitis, in this case, pigmentary lymphoplasmacytic keratitis. They also talk about KCS, which is keratoconjunctivitis sicca. In the end, on the late stages of the disease, chronic keratitis, KCS, exposure keratopathy, it will all look the same. We have hyperplastic corneal epithelium with keratinization, plus or minus pigmentation, and degree of inflammation. Another interesting thing is the fact that if you go to the conjunctival epithelium, you can see how the epithelium here, the conjunctival epithelium is usually a Here we go again with the color change. There you go. The conjunctival epithelium usually has lots of goblet cells, right? And you can see here there's complete loss of goblet cells and keratinization of the epithelium. So this is a squamous metaplasia of the conjunctival epithelium, which also goes along with both exposure and KCS. So it all fits. We have published well, the rest of the eye is normal, so we'll leave it at that. Was that right?
Showing the asteroid box.
Oh, right.
Probably.
Yeah, that's what we're here for.
That is for.
I know. No, I like
Why
it.
they send the onion?
Right. So unfortunately, it's not as impressive as the clinical or the gross image, but here they are.
Oh,
These are the asteroid bodies. They are cute. Though. So these are concretions of the vitreous associated with age. It's an age-related change in dogs, but can also be more prominent in dogs with some specific diseases like melanocytomas or melanocytic ocular tumors. They will develop a lot of asteroid hyalosis, uveal melanosis, like in the Cairn terriers, or iridociliary adenomas. As we joke, we get an iridociliary adenoma without asteroid bodies. We get pissed because it's not fair. We want to see them. Those dogs that don't read the book, we really get mad about it. Anyway, back to the PowerPoint. So our diagnosis, corneal squamous cell carcinoma with the keratoconjunctivitis sicca. There's a history of facial nerve paralysis, right? So that also probably added to or was the cause of the keratoconjunctivitis sicca, and there's pigmentary keratitis. So as far as the overall health of this corneal surface in this dog, there's a lot going on. And they didn't mention if this dog was being treated, but we know that chronic keratitis or chronic usage of immune suppressive drugs are predisposing factors for the development of corneal squamous cell carcinoma in dogs. It's really hard to separate the influence of the inflammation, the chronic disease, and the treatment, because they usually go together, right? If you got a dog with KCS and chronic keratitis, they are usually treated for the disease with immune suppressives for a long time. But we know that there's that relationship. We don't know about treatments specifically in this case, but we know that there was everything else in there. All right, now this next one. It does look interesting. This is an 11-year-old Cairn terrier, a female spayed. We got the left eye. The eye was enucleated due to a melting corneal ulcer, which progressed to a corneal perforation with, as you can see, partial lens extrusion. The lens is just plugging the whole defect there. Almost like a ring with a diamond on top. So I'm impressed that the lens stayed in situ there, and we received it all together. It was nicely tucked in there. So they have a presumptive diagnosis of bilateral ocular melanosis of the Cairn Terrier breed. There's some adnexal melanosis, meaning pigmentation around the ocular tissues. Multifocal nodular pigmented scleral swellings on both eyes, and this is all bilateral. Unknown about glaucoma, of course, right? Every time you have a big hole in the eye like that, the diagnosis of increase intraocular pressure becomes a problem. But what we can see so far, besides the obvious corneal perforation and the anterior lens luxation and prolapse, it's a markedly expanded uveal tissue. So here's the iris, ciliary body, and choroid. So it's very dark, black, and expanded. Probably some of the retina there. The vitreous is a little bit liquefied, right? The optic nerve is right there. But we're going to take a look at the uveal tissue and take a look at that cornea. Okay. Here is the slide. It's subgross. See how heavily pigmented that whole uvea is, right? The lens fell back into the eye, but the defect in the cornea there is pretty obvious. Here's that detached retina that we've seen grossly. Here's the optic nerve and the markedly pigmented, not only iris, ciliary body, and choroid, the overall uvea, but you can see that extension of the pigment into the episclera, like they describe those episcleral plaques, and into the limbo and equatorial sclera right there. Okay. So let's deal with the corneal disease first. So right there, there is an obvious defect. Let's see if it's going to accept the arrow there. A defect. The epithelium is migrating over the lost stroma and almost contacting this ruptured descemes membrane, which is kind of flapping in the wind over there. Well, it wasn't, right? It was surrounding the protruding lens. Let's put it that way. In these cases, what we like to do, we look at the corneal stroma adjacent to the defect. So we have a lot of vascularization. You can see how the epithelium and the stroma meet at an angle right there. So there's an acute angle, or they're perpendicular to each other, suggesting that the epithelium is growing over a stromal defect, as opposed to where you would expect to see where the epithelium is, of course, parallel to the collagen fibers of the stroma. And right there, we see some interesting features where the epithelium itself, the corneal epithelium is kind of diving down the corneal stroma, right? And that suggests collagenylysis or corneal stromal malacia or melting, meaning there's a liquefaction of the stroma. The epithelial cells, they lose their capacity to stay in touch with their basement membrane epithelium, and then they basically dive down into the liquefied stroma. And that's one of the ways that we confirm the presence of collagenylysis or corneal stromal melting or malacia, right? So we know what caused the perforation here. There's some degree of corneal stromal malacia, and that can happen pretty fast, and it can be very impressive. Glad that doesn't happen with us humans. Otherwise, every corneal disease or every corneal lesion could be a reason for a medical visit, because if that happens, you just lose your cornea right away, like dogs. So that's the perforation, much more acute process compared to the rest. The lens was in that plate, filling up the gap there. But let's focus on the uveal disease. You can see how markedly expanded and distorted the iris, the ciliary body, and the choroid is. It's a little bit harder to see the choroid because there's some degree of congestion there, but it is expanded. Even the portions of the choroidal tissue that surround the optic nerve are markedly pigmented, just going around once. This is distorted by the pigmentation, but also because of the eye. It's a little bit deflated, and you can see that extension of those cells into the episclera and bulbar conjunctiva. This is classic for ocular melanosis. Don't worry about, that's for the pathologists out there. Don't worry about the fact that these cells are infiltrating the sclera, that they're forming, like that they present a behavior that kind of looks neoplastic. But we see that with melanosis all the time. The main features here are the fact that, and this is not going to show really well there because the camera doesn't really like super dark things. But the main thing is the presence of these basically round, very plump, pigment-laden cells. They do not form an obvious, well-delineated mass like you would see in a tumor, and you don't have obvious neoplastic characteristics of those cells, which in this case would be either a double population of cells or more anaplastic cells with mitotic figures and pleomorphism, etc. So this is, and in a Cairn terrier, it makes it easier because it's classic for the breed. We see this lesion in non-Cairn terriers also, so be aware of that. But this is uveal melanosis of the Cairn terrier breed in this case, right? So likely there was melanosis to begin with, maybe glaucoma that led to either lens luxation or corneal decompensation, an ulcer that evolved to a collagenolisis rupture. The lens decided to take a hike and wasn't successful in leaving the eye, got stuck there. But the important thing is to identify that the corneal lesions are very acute, but there was a background of melanosis there, as with the, we confirmed with the clinical presentation and with the histologic appearance. The optic nerve looks normal. The retina is detached, and it's not obviously torn, but it's definitely detached. And there are relatively good numbers of ganglion cells throughout the retina. So it's hard for us to confirm or to assess the presence of glaucoma prior to the perforation. It doesn't seem like it was the case. So likely something happened to the cornea along with the melanosis that led to the corneal perforation. So our final diagnosis, ocular or uveal or ocular melanosis, typical of the Cairn terrier breed, focally extensive corneal perforation with marked neutrophilic and collagenolated keratitis, and lens luxation and prolapse. All right, so this is what we have for today. Thanks for joining us in person and online, and we'll see you guys in 2 weeks. You're welcome. Have a good day.